Good morning, everyone. Thanks so much for joining us today for what should prove to be an informative and invigorating discussion centered on the state of the long-term care industry and the tension between federal policymakers and senior care. My name is David Morrissy, and I'm a partner here at Garfunkel Wild, heading up the law firm's Washington, D.C. office and its expansion into the Mid-Atlantic region. I also have strong ties to our main office and my New York client base after having lived and worked in New York for almost 2 decades earlier in my career. However, through representing and counseling nursing home owners and operators through all facets of their business, it's become abundantly clear to me that the topics we're going to cover today aren't limited geographically to where I am and where I've been, but the long-term care sector in every region of our country. With me today is a man who, in this arena, should not need an introduction, the esteemed Clifton Porter II, the president and CEO of the American Healthcare Association and the National Center for Assisted Living. Cliff has dedicated his career to serving the needs of seniors in long-term care. He began his career as an administrator in training at a skilled nursing facility, serves as an administrator of several skilled nursing centers for about a decade after that, and capped his operational experience as a regional director of operations for a large urban market for several years. After that, he pivoted away from operations and employed his depth and breadth of long-term care expertise by leading a senior care providers government relations team and serving on various state healthcare association boards. Clif is now the top lobbyist in AHCA and NCAL and tirelessly works to promote the association's legislative agenda. Under his leadership, AHCA and NCAL have been deeply involved in many legislative accomplishments, which are, well, to be frank, there are too many to list off, but I think one worth noting is leading the COVID response negotiations with the White House and Congress and ensuring billions of dollars in support for our industry during the pandemic. Welcome, Clif.
Great to be here.
Thanks for being here. So, let's start this off broadly. We've now emerged from the pandemic in the industry, but the rebuilding continues. How would you describe the current state of long-term care in America?
Well, I think, and again, thanks for having me, and I'm really excited to be talking with the group. Again, you had articulated how long I've been working in the sector, and it's been 36 years. And I must say, I think we're in the strongest position that we've ever been. And that's a bit strange or odd to think about in some ways because, obviously we've had a variety of different ups and downs over those 36 years I've been in the business. But when you really think about where we are as a sector, and most importantly, what we've emerged from, I think we emerged from the pandemic stronger than we ever have. I think it made us better. I think that the pandemic itself had some silver linings, particularly relating to our relationships with policymakers, and more importantly, the understanding that there has to be health within the entire healthcare ecosystem for the whole thing to work. If one breaks down, everything breaks down. So as a result, I think there's just a general greater appreciation for the work that we do in long-term care and the importance of what we do, not just as it relates to serving seniors and serving folks that have disabilities, but also the healthcare system writ large. That, again, if nursing facilities aren't able to take patients and hospitals can't discharge them, if hospitals can't discharge them, then people can't get services and they have to wait. And it just creates a variety of bottlenecks. So that's one big component of it. I think the second and the most compelling of all is the incredible demographic shift that we're seeing in our country right now. When you look at America, and again, years ago we talked about it in theory. I remember in undergrad reading Megatrends. That was a book that was hot in the 80s, talking about the future. And one of them was the aging of America, and that was all a theory, not a theory, but just a prediction. And they were trying to think about what the world would look like when all this transpired. And I think, again, in our case, we are now in it. It's not coming. We're there. 4 million people will turn 80 between now and 2030. which is the greatest growth curve that we've seen in American history in that age cohort. Another 4 million in the 5 years after that, another 4 million in the 5 years after that, and about another 3 million in the 10 years after that. So, when you look at 25 years, there's 15 million more folks that are at the age of 80. And obviously that is the age cohort where they need long-term care of some sort. So demand is, again, going to overtake us. And I think that's exciting. It presents a tremendous amount of challenges, of course. But as with anything, if you've got demand for service, we kind of figure out how to make that work. That's a good problem to have, and I think overall we're in a great position.
Yeah, that's really a staggering. Those are some staggering numbers that you discussed. I mean, just to think that by 2030 alone, the country is going to be home to nearly 19 million people who are 80 or older is something that I probably would not have ever thought was going to be the case. Even now, working in the industry, before sort of reading the statistics. So it's clear that, there it doesn't seem like the need for long-term care and post-acute care is going anywhere. So, I think that it is important, and obviously people like you of integral importance to the industry, because we do face challenges as we're going to try to meet the demand that you discussed. There are obviously hurdles to clear along the way. There are workforce challenges, there's financial pressures, there's complex regulations, and part of my job as an attorney is to try to sort of pinpoint opportunity within legal challenges. And I think you sort of do the same thing. You see these challenges as an opportunity to sort of strengthen and modernize how we deliver care. I've seen you speak multiple times. I see what you're doing, and it's tireless and innovative towards that modernization. So I thought perhaps today we could sort of touch on those various challenges that the industry is facing or will face, get your thoughts on it, and get your thoughts on how, I, as an attorney, can sort of assist with bringing this industry into the future, and how people who are watching us today can help bring us into the future. If you don't mind, we can, start with
Yeah.
the workforce challenges. There's that's a not only do we represent as attorneys buyers and sellers of long-term care facilities, we serve as regulatory and licensing counsel. We litigate disputes for owners and operators, and that includes employment issues. And we serve as de facto outside general counsel, trying to assist clients with, navigating these issues and working through these challenges. Of seeing, firsthand the necessity as an industry to build a more efficient or better way forward to serve our seniors. Sorry, that was a not unintentional segue into AHCA and NCAL's A Better Way. It's almost like I planned it, right? So, but A Better
Yeah.
Way is the name for AHCA's forward-looking policy agenda to deliver bold solutions for quality long-term and post-acute care. So, I guess if we could sort of go over the framework and then get into how we're addressing the workforce issues, and then beyond, how the framework affects, other areas, other challenges the industry faces beyond workforce. That will, I think, pretty much take our time. It could probably
Yeah.
take more.
Yeah, no doubt. David, you touched on some incredibly important points. When you look at the sector, I can just make the reference of the time that I've been involved. We have essentially had a transformative run when it comes to the type of patients we take care of, the type of facilities that we operate, the specialization that now exists in long-term care. That you've got dialysis units and cardiac care units and a variety of different products that are now delivered in long-term care facilities. All these things essentially are developments and in response to the market changes that have occurred over the last 36 years. When I began in the business in 1989, basically the only places that cared for the elderly were nursing homes. There weren't a variety of other care alternatives. Adult daycare didn't exist. Assisted living was in its infancy. Independent living existed to some degree. Home care existed to some degree. But all of these different programs that we now see as it relates to alternatives, particularly early in the aging process, used to all come to long-term care and now are completely and totally in the community. So the industry's had to transform and has had to effectively increase the capabilities of our delivery system to deal with higher acuity patients. So it's not just subacute care, it's more intensive rehab, it's a variety of different things that we do. And with that modernization and change, the regulatory and sort of construct that we have statutorily has been unchanged. As recent as when I started, in 1989 with OBRA 87, the implementation of OBRA 87 was right at the front end of my career, where we went to a different regulatory construct and view that, frankly, I think was a positive for the sector as it relates to really thinking about things through the eyes of the patient, improving quality of life, looking at quality of care and the things that matter. And then prior to that, there are even some vestiges of law and regulation that have existed since 1965, before I was born. So we're still living in a construct that is largely unchanged and has not adapted in the same way that the marketplace has shifted and changed. So with that, we have, as you aptly said, dubbed, this, there's a better way. That the old way is, or the existing way is one that no one is satisfied with. Consumers aren't, regulators aren't, lawmakers and policymakers aren't, we aren't as providers, patients aren't, I mean, you name it, families aren't. No one is satisfied with the system. And as a result, there has to be a better way. And what we're doing is we're advancing some policy proposals that hopefully will help modernize how we're seen, viewed, and ultimately help us take better care of the people that we serve, and more importantly, prepare for this deluge of residents that are going to need our services. So your point about workforce is incredibly important, and in my view, is the number one existential long-range issue that we're going to be facing over the next 20 years. As beautiful as that graph is relating to demand of having 15 million more people potentially needing our services at some point past the age of 80, you have sort of the consequential challenge of who's going to take care of them. And there's a similar data point I'll share with you, today in 2025, essentially, the 18 to 45-year-old is the cohort that does the physical delivery of care to our patients. And that's something that AI will never replace. You're going to need a person to bathe someone and to interact with them, to feed them, to clean them up and do the activities of daily living. And that is never going to change because none of us, including me, you, wants a robot doing that kind of stuff. This is an intimate, service. And we're going to demand that we deal with human beings. So with that, we've got to recognize that the 18 to 45-year-old is the strong, physically strong group of folks that actually are going to be able to deliver the care that these folks need. And today there's 8.29 18 to 45-year-olds for every 80-year-old. When you fast forward to 2040, that's cut in half to 4. So 4 18 to 45-year-olds.
Astounding.
Yeah.
That's an astounding number.
Four for every 80-year-old by 2040. And obviously, 2047 is when I turn 80, so I'm pretty concerned about that personally. But that is a staggering statistic. And again, I think our sector is being innovative and doing a lot of different things to help uh, create some level of opportunity to attract those key workers. Same thing applies to leadership and basically every role in the facility. A lot of work is being done, but we got to have like big solutions to deal with this, because these are what I call sociological issues that we have in our country, relating to birth rates and how many kids you have and when you have them. And this is not, my grandparents' generation, who had my dad when he was 17, and he grew up knowing his great grandparents, and they didn't pass away until he was a teenager, because everyone had lots of children, had them much younger. We're not in that phase of society any longer, and as a result, it creates some real significant challenges. And that's just the start when it comes to better way. I mean, obviously, workforce is a big challenge. We've got to continue to ensure that we've got the reimbursement that's adequate to deliver on the promise that the public expects. And as it stands right now, it's woefully inadequate, particularly in the area of Medicaid and Medicare Advantage. Obviously, Medicare Advantage continues to be a growing component of our payer mix, and that remains to be a challenge. Lots of controversy and issues as it relates to Medicare Advantage, and then obviously the most important thing, and hopefully is the thing that I leave when I'm done, and that is uh, making this irrational regulatory environment more rational. And we don't argue that there should be regulation in our space. It has to be. We have very vulnerable people that depend on us. But the current system that we have is completely irrational, and it does not improve quality. It does not improve care. Frankly, it does the opposite. It undermines quality and undermines care. And that has to change. It must change. And our agenda is laser focused on all four of those objectives to hopefully make a difference in the next few years.
Yeah, and I'm sure you will, given how tirelessly you work. But I don't want to paint a doomsday picture. So, we've articulated the challenges, and look, I'm a cynical lawyer, so I'm sure I will continually repeat the challenges, perhaps in more negative a light than I need to. But seeing you operate, I know that you sort of um, present these hurdles as positively, like as
Yeah.
pillars to the better way, right?
Yep.
So it's an opportunity that you've had and succeeded with in sort of pinpointing these opportunities within the challenges. But kind of circling back to workforce shortages, it's just for my clients, it's a persistent challenge, right? So how do we turn this challenge positive? Because you've mentioned some numbers that are sort of staggering, right? Just in a vacuum, simply the number of 80-year-old plus people that we will have living in the country alone in a vacuum is a number that will catch people's attention. The number of the sort of, I'm sorry, is it 18 to 45?
Yes.
That
Yes.
demographic,
Yep.
in relation to the number of people who are of age to receive long-term care, the reduction in that ratio was a number that I personally hadn't sort of delved into. So that was startling as well. And not only do we have that, but we couple that with the fact that it seems like every other healthcare sector has like fully rebounded from COVID. But our industry, it's like the workforce levels in comparison to the pre-pandemic workforce levels are still like markedly lower today, 5 years later. Um, maybe around 60,000 less people in the workforce. And with the aging population, it seems like we're almost going in two different directions. So it's a tough gap to span. And because of, maybe you can correct me if I'm wrong, but maybe partially because of that, there's been a difficulty in providing the care that's necessary, in staffing the nursing homes that exist, in continuing quality with some of the nursing homes that do exist. And in the last few years, I mean, it's like a pretty astounding number of nursing homes have closed, and so residents are displaced. So, one of the challenges that my clients face is they, I don't want to say that their workforce is the first stop into nursing for many of their employees, but they sense that they are educating their employees, and these employees are gaining these skills in nursing and being nursing assistants, and frankly, the job is tough. I mean, it's not firsthand, it is not the easiest job in the healthcare industry, and it's also not the highest paying job. So we're struggling with trying um, to maintain our workforce at these facilities in a way that really delivers the quality of care that we want to. So, how is it that you see that sort of Congress can help with workforce, and what practical policy solutions are needed to address this very serious situation?
Yeah, I mean, it's super complex, as you can imagine. I mean, obviously, the workforce challenges that we face specifically in long-term care are, you know, basically the workforce challenges that a lot of industries in America are facing today, right? And the current immigration discussion that we're seeing. I mean, you see farm workers being impacted by that. Again, the similar types of work as it relates to pay scales, et cetera. It's just again a sociological problem that we have, that's sort of fundamental to just basic decisions that our young people are making, as it relates to how they're going to live their lives and how they're going to build and develop their families. So this is a real issue, and it's not going anywhere. And again, I'm just a big believer that it can't completely be fixed, if not or even significantly fixed by Washington. Part of it is Washington for sure, but most of it, in my view at least, fundamentally deals with us, meaning operators, adapting to the new environment that we're in. And as with anything, we're in a situation where market forces drive demand, it drives wages. You sort of have all of this, free market things going on, and we've significantly seen a shift in the market post-pandemic. And to me, at least is our view that, obviously you've got to be best in class as it relates to how you treat employees. They've got to feel heard. They've got to be paid competitively. They have to be led well. All those things are important to essentially bolster retention. And then as it relates to recruitment, you've got to approach things differently also. And I've seen a lot of providers around the country take dramatically different steps and approaches to actually recruiting staff, that has actually made a big difference. When you look at the data line on labor in our sector, we had a bottom, obviously, and we've sort of been slowly climbing out and getting back to pre-pandemic levels. You rightfully noted that we're not there yet, and we still have a ways to go, and we still have work to do. So that said, we've got to really think differently as it relates to how we engage with our teams and with our staff. That's on us. And then I think the other component of the Better Way essentially addresses it as well. One of the reasons that it's hard, one of the reasons that registered nurses decide, I can work in a physician's office and I don't want to do this anymore because it's just too much, is because we have an irrational regulatory system. And the burden of that is such that it drives people away. It drives administrators out of our business. It drives nurses out of our business. It drives nurse leaders out of our business because there are just other options and other opportunities, no matter how much you care about the mission of what we do. And I fundamentally feel like we have the best and most attractive mission of any space in healthcare, which is loving on and caring for our seniors. I mean, these are the folks that made our today. They
Yeah.
worked hard to build our today. So this is, it's an honor to do it. But when you have all of these, headwinds coming at you, the question gets down to why. And I think in many cases, COVID absolutely caused people to be like, I'm not doing this anymore. This is crazy. And so we've got to fundamentally change the way we are regulated. And I think if we do that in a way that is not solely punitive, that is more collaborative, that is focused on outcomes and improving care for patients, that deals with providers that operate in good faith differently than providers that operate in bad faith. Right now, we have a bad faith system for everybody. Bad things happen in nursing homes, bad things happen at home, bad things happen on the street corner. This is just life in society. And the real question for us, and the way it used to be even when I was operating as an administrator, was it was more rational in the sense that what they wanted to know was, okay, Cliff, one, did you report the bad thing that happened? Yes, I did. Okay, what did you do to protect or respond to that bad thing? Did you protect everything? Yes. What did you do beforehand to predict and prevent that from happening? A lot. And most importantly, what are we doing in the future and what do we learn from it to try to minimize the risk of that happening again in the future? And if you were able to demonstrate that, you weren't even cited. You weren't cited. That was the purpose of the investigation. They were checking to see that you had systems that work. And we've got to get back to that, because if we have something that's predictable, something that's manageable, something that serves the patient, workers, particularly folks that are in healthcare, I think will be in a situation where all of the great feel good psychic benefits that we get from loving on the elderly, that scale begins to tilt in that direction, and all the regulatory stuff lightens up a bit, and I think we end up being in a situation where we can get more folks. But David, it's tough, and there is no single answer. We just
Yeah.
got a lot of work to do. We got a lot of work to do.
You just went through um, a lot of work, and we could spend a lot of time on a few of the different topics you just talked about. But I think it's interesting the shift you have noticed in your own career, sort of towards what I think my clients feel is a strictly punitive regulatory system. It's not a system that engenders goodwill and and participation in the way that I'm sure the government would like. And so it's just not efficient, and it doesn't add to the sort of quality of care, because it really changes the attitude of the owners and operators toward what they're doing. And talking about the people that work in our industry, in that sort of demographic you talked about that we need to keep engaged. It's like these folks who I've seen, who I've met, are extremely passionate about what they do. And I was just at the sort of the annual conference that the Lifespan Network puts on, which is the largest senior care provider association in the Mid-Atlantic, and they're operating in Maryland. And meeting some of the people there and the passion that they have for the work, it's it's almost like there's a disconnect, because there needs to be practicality where to meet that passion.
Yeah.
So, I know that you're doing a lot of the work trying to blaze that trail it towards the practicality, and you're calling for sort of a variety of federal investments and policies. So, could you just talk? I know we have to move on from workforce, but just very briefly about, how do we build the caregiver pipeline? How do we attract the people to the long-term care field and help them grow and develop it as a career? I know you mentioned, so I don't want to state this for you, but a lot of it is on the owners and operators. We can't rely on the federal government to help build the business, right? That's
Right, right, right,
so.
right. Yeah. No, I think well, a couple things. First and foremost, I view the work here as sort of a thousand little things that will. It's not one big thing. People say, well, immigration reform, and if we could just, I used to, and I agree. If the goal is legal citizens or tax-paying citizens, I could send buses to the southern border, and anybody that wants to be a nursing assistant or a nurse, if the country had a policy where you sign a paper and we're going to sign you up and put you in a class and you can get a green card and be a legal citizen, we'd solve a lot of our problems that way. And that's all true, right? But that's not going to happen. As rational as that is, the politics in our country, and you see how extreme we've gotten as it relates to the politics around immigration. It's just not possible. So we gotta move on from that and keep it in the back of our mind for future solutions. But in the here and now, it's not a political possibility. So then you have to think about, okay, well, how do we work with what we have? And I think we've had some early success. We've had some recent announcements from CMS and the Trump administration that CMP dollars are going to be leveraged and used up to $300 million. If states choose to participate, the federal government will match. If you use your CMP dollars that you've accumulated in your state and you decide to dedicate them towards workforce development and long-term care specifically, uh, tuition forgiveness, loan forgiveness, specific training costs, a variety of things to help get more nurses in our field. If you make that choice, then they're going to leverage those resources to help you achieve those goals. And that's a pretty compelling shift in policy. And we're excited about that. We think that's one of those other, kind of incremental things that we're seeing in the near term that will help address the workforce challenges. Uh, I think there are a variety of other things that has to happen, and I think it has to just be just a super significant investment. And that is we need to have a very real, aggressive rural workforce strategy of how are we attracting registered nurses in particular to what I call the frontier. There are still there's rural and then there's frontier. There are very rural places, and we've got to think very differently about how we deliver care. When we were going through the staffing mandate debate over the last couple of years, I mean, I learned pretty quickly, there are counties in America that a registered nurse doesn't live in. I mean, there's just not one that even lives there. So, this issue is particularly acute in rural areas, and that's a challenge as well. So, we could go into it. I mean, so many details. We've got, boards of nursing that in some cases are impediments to getting more folks licensed based on the way their policies are established and written. And obviously that's just trying to control supply. But, at the end of the day, we need more supply, and nobody's going to lose their job being a nurse if there is more supply of nurses. But we sort of have these policies that are a bit dated, that haven't changed, and the nursing boards have a little bit more sway on controlling supply than probably the market demands. So, like you said, we could talk for hours about it, but a lot of opportunity.
And one of the items you mentioned was funding, right? Money. And so money comes from various places. Obviously, Medicaid underpins much of nursing home funding. And I think the last time I read, two-thirds of nursing home residents rely on Medicaid to cover their care. So, how does a better way sort of tackle Medicaid and reimbursements?
Yeah, no, it's a great question. So I think a couple of things. I think, on the Medicaid front, the goal is to work at getting and closing the $18 a day on average deficit that the Medicaid program currently pays for long-term care. Now, again, that's a national average. You've got some that fall more generously, some that fall, more significantly in the other direction. But there's clearly a gap, and we've got to work on ways to close that. And that is another fundamental challenge we're going to have going forward, because as more and more and more people need our services, there's going to be more and more and more need, and it's going to cost more and more and more money just to deliver the care we're already delivering, much less close the gap. So that's a reality, but I'm somewhat optimistic about the policy uh, sort of thoughts and direction as it relates to the future, because in spite of that challenge, and it is a massive challenge, the reality is when it comes to public policy, priorities are the priorities of the people. And I'm finding now more than ever, and again, I laugh, but I'm sort of Clif Porter's the case manager for Congress when someone needs a placement in a nursing home. I literally get calls all the time based on these relationships of a member that needs to have their wife taken care of. I mean, it goes on and on and on. So we're doing this almost every day, but that's gonna quintuple over time. So what that means is that policymakers are all of a sudden going to be faced with, how do I take care of my mother? She's home, and wait a minute, what do you mean Medicaid doesn't pay cost? What do you mean? So I can't get her in a place because, so they get an awareness because it becomes personal. And I always say that, we can find the money. The money ain't the problem. We got plenty of money. It's really about the priorities of how we spend the money. And I do think that this demand is going to help fix that. So we got to continue to do the work of relationships. We got to continue to do the work of improving quality, because we got to have a quality product. And then I think if we can continue to do that, continue to obviously emphasize developing our workforce, improving quality, improving our image, as this need explodes, we're going to have more and more folks, particularly policymakers, that need our services. And in needing those services, guess what? They're going to change their priorities. I mean, I always use the analogy. Look, I don't know what the plane is. I forget what it is. I think it's what's the stealth bomber? It's $1.5 billion for one of them. One. So we say we don't have any money, but it's $1.5 billion for one. Our Medicare market basket increase is less than a plane.
Hmm.
Less than a plane. So what if we said we're going to invest 10, build 10 less planes? And I know I'm simplifying this way beyond the way it really works, but 10 less planes would fundamentally change how we fund long-term care. And it is hard, but it's easy at the same time. And we got to get them to lean a bit more on the easy, and hopefully get us in a position where we can strengthen Medicaid for the future and ultimately have a model that can deliver on the promises that our society expects.
Yeah, that's really interesting that, and not shocking at all that I guess when once an issue directly personally impacts a policymaker, then they'll view it from a different perspective, right? So hopefully these policymakers, when they encounter these issues, will make it a priority to make sort of reimbursement predictable and sustainable and fair. But and then pivoting from Medicaid, something you mentioned earlier is that Medicare Advantage has become dominant. Probably because it offers perks that are appealing to seniors, like out-of-pocket limits, vision, dental, hearing, and sort of other supplemental benefits. How is it interacting with post-acute and long-term care, and what does the policy agenda advocate for relating to Medicare Advantage?
Yeah, well, Medicare Advantage again is growing, frankly, the largest payor for Medicare services now as compared to fee for service. We are at about 54% of patient days are paid for by Medicare Advantage, 46% are fee for service. Now, obviously, every market's different, so I'm not arguing that, but that's the general statistic as it relates to sort of how this shift has occurred. And this has happened. I mean, you talk about this shift. I mean, this has happened within the last decade. I mean, when I was operating, even 15 years ago. I mean, I think it was something like 12% penetration in Medicare Advantage. I mean, and we were worried it was getting to 20. Oh God, it's getting to 20. But we're already, we've already at the tipping point when it comes to that. So Is Medicare Advantage inherently bad? No, it's not. But I'll say it, and I'll say it bluntly, and I say it to anybody that wants to listen. Uh, Medicare Advantage plans have taken advantage of providers and taken advantage of the challenges that providers have in delivering care. And in doing so, have had a significantly negative impact on their beneficiaries. And that's really what it's about. It's not just about me and the hassle. When I say me, the operator, I'm still an operator. You know, I still think that way. I have my administrator's licenses still looking at me in the face to remind me that I'm still an operator. But look, we have to take care of people, and we have complex systems, and all of it's hard and all that. But it's not even about me. If you look at what's happening to the Medicare Advantage patient, you have a variety of denying and delay for care. Patients, when you're 85 and 87, what do you need? Health care. I didn't need it when I was 30. I need it now. I need as much of it as I can get, because this is when my systems and my needs for healthcare increase exponentially. And the strategy has been to deny, to delay, and ultimately discourage patients from pursuing the benefits that they've earned and that they deserve, and that I frankly think were never intended for them to be deprived of. So that is a huge issue. We've got, obviously, a survey that we did. 2/3 of our operators have basically reported that MA plans deny or delay care on a daily or weekly basis. I've experienced it personally with my own uncle and trying to take care of him. He had a Medicare Advantage plan, and literally, and I'm an expert, right? I'm an expert, and I'm on the phone every 48 hours fighting to ensure that he gets the therapy that he needs. And in his specific case, I was even fighting. They were trying to discharge him when he was actually still fainting because his blood pressure wasn't right. And I'm like, you're not sending him home, and he can't, he's fainting. That's going to create another break, and it's just going to create a whole cascading things of a series of events. So it's that kind of, and I'm an expert, and they're not going to exhaust me, but because I know that's how the game is played. But just think about that 90-year-old husband that's trying to take care of his 88-year-old wife, and they tell him no, and he tries again, they tell him no again. He's going to quit. He's going to quit because he's exhausted, and that to me is unconscionable and morally corrupt. And we got to do something about it. So a part of the better way is to really address these vagaries head on. And you're seeing it in the public policy space all over the place. I mean, this is not anything that's just happening in nursing homes. Hospitals are having the same problem. And there is a growing criticism from policymakers on both sides of the aisle, particularly with Medicare Advantage, at AI and other models determining whether or not you get care. I mean, this is a physician decision. It's not. I don't want an AI, program or algorithm making a decision. It may advise a decision, but it shouldn't be making the decision about whether or not I receive care. So this is a real issue for us, and we are going to address it frontally. I have no shame to call a spade a spade. And if you're taking advantage of people, I'm going to call you on it. And we're going to do that. And it's our hope, and I think we have a very, very legitimate shot of changing statute in a way that it actually does create some guardrails here that more or less protect patients to ensure that they get the care that they need when they need it. One last statistic I thought was very interesting. For the last quarter, for the first time since the existence of Medicare Advantage, there was a decline in enrollment. Okay, so just think about it. A decline in Medicare Advantage enrollment, increased public outcry, increased attention, informs beneficiaries. I'm hearing this. If I'm a child of a parent that needs or is going to Medicare, or in my case, in a few years needing Medicare, I'm telling them might want to stay fee for service. You can afford to do that. That's it's not a must that you do this. It's not a must that you get the gym benefit and all these other things, because you're trading that for when in the near term, a early sugar benefit, I call it, versus thinking longer that, okay, at 65, I'm still pretty young when it comes to my healthcare needs. At 85, I'm going to be a completely different person, and I need to plan for being 85, not just the benefits of being 65. So we're going to shine all that light on all these issues until we see a change, because it's not, it really isn't. It's hard for us as providers for sure. Reimbursements, sure, they pay less, they want to pay less. They do everything to pay less than PDPM requires, all that stuff. But that's just part of what we do. If we can address the issues as it relates to how it impacts beneficiaries, a lot of the provider problems are going to be solved. So that's our focus.
Yeah, that makes sense. It's it's a long road and a heavy lift, but you articulate it well. So hopefully it you gain or continue to have traction with it. We so sort of closing the loop on the pillars of a better way. We've talked about workforce, we've talked about reimbursement, and throughout we've kind of talked about the third pillar, which is sort of a more rational regulatory environment. So, and just, if you want to add anything else about that, I know I've heard you talk about it before. Probably hear you talk about it again at some point, but ha what is AHCA proposing to make the regulatory environment more rational? And then, that, I guess, into, um, looking ahead, what does the next 5 years look like? What does success look like to you? I guess globally, after you
Yeah.
add anything you want about the sort of regulatory environment and
Yeah.
modernizing it.
No. I mean, look, the system has always needed work. It's beyond needing work now. We need to totally and completely restructure how we regulate our sector. And I think, when we think about our regulatory construct and environment, and again, we're talking 67 pages of recommendations that we made. So I'm not gonna get into every detail, but I'm gonna just hit some highlights. So for my fellow administrators out there that may be listening and operators, okay, just imagine a world with me for a minute, where if you are a top performing facility, you potentially could opt to have deemed status with some other regulatory construct. The complaint process is the same. So the current, complaint process has to remain the same. So again, if there are complaints and there are problems and there's a shift in leadership and, good building has all of a sudden become bad based on these, repetitive complaints, then yes, there's still a catch, if you will, or a safety net for the beneficiary in that case. But if you're a consistent facility, and I know many of them around the country, same leadership, just consistent, they do it and do it, extremely well. Why should they be regulated at the same level that the lowest common denominator is? And right now, it's the same for everybody. We treat the entire nursing home sector like the least common denominator. So let's differentiate that. What does that do? That creates an incentive, right? If I can improve my care and improve the outcomes and get deemed to be qualified to be in this particular bucket, that's a motivation to me as an operator. That's going to save me money. So I'm now be motivated and have the right motivation to essentially get to a level of quality that essentially puts me in an environment where I can be regulated differently. So that's a big one. That's a long shot, but it's a big one, and we're pushing for it. The other is some simple fixes. One is the issue of strict liability. This is a relatively new interpretation. I described my time as an administrator. Last building I ran was in 1998. When I was an administrator, big building, complex building, but there was not a strict liability standard. The question was, okay, did you report it or did we find out about it on our own? What did you do about it? What did you do to protect the patients? What was your subsequent actions? How did you improve your system after the incident occurred? Now you get an IJ because it happened. It happened. The patient fell, never fell before, ever. They fell this time for some reason that we haven't figured out yet, and they had a subdural hematoma, and that's an IJ, and deal with it. Here's a fine because it happened. I joke, and I'm being real. I'm 58 now. I fell a month ago. Why? Because I got up out of bed too soon and my foot cramped up and I fell. That's just, I guess, a 58-year-old kind of thing that happens to you when you're 58. Your feet cramp for no reason. But I fell. Now I didn't
It's
injure.
clearly your caregiver's
Yeah,
fault,
yeah,
right?
exactly. Right, right. So the point really is that look, I mean, these things happen in real life. And the standard that we're under with a strict liability standard that was essentially implemented during the requirements of participation regulations that President Obama put in place in 2016 when he was leaving office, we're still living under the pall of that particular regulation. That can be fixed. The Trump administration could fix that by memo, and we're asking them to do that. And that's a big deal because if obviously we can resolve that interpretation, that's going to change the dynamic on CMPs. That's going to change the dynamic on IJs. It's going to have a cascading effect on a variety of other areas. And I think ultimately it will improve care because we're going to get back to not reacting in fear, but reacting proactively and systemically to build, systems that ultimately ensure patients get care and improve quality. So that's an example. I mean, obviously CMPs is another. We should have, a more collaborative system. So why should we, California, as an example, has a model where they have a technical assistance division. Okay, so and there's a firewall between them and the regulators. And this technical assistance division, based on the direction of the person that runs the regulatory body, says, okay, you need to call this TA center to get help to fix this problem. We found this IJ, but the TA people need to go in and try to help you resolve it. So the whole idea is to try to get back into compliance. So these are the kind of things that we need to shift. It can't be about the goal is to close you and that you're on the cycle to close you. And if you don't get it fixed in 6 months, you're closed.
That's what operators feel right
Yeah,
now.
well,
Feeling.
absolutely. And it is beyond discouraging. And again, if you don't, and again, there have been times, and we gotta be own it. Sometimes we deserve an IJ. But it happens. But
None of
it's
my clients.
Yeah, yeah,
Just
none of your clients. But sometimes we do. But that is rare. That's not the norm. And right now, it doesn't matter. It happened. The patient wandered. You got them back in 5 minutes. No one was injured. You put a system in place to ensure it didn't happen again. And just because it happened, I'm gonna give you an IJ for it. That has to change. So a lot of these policies that we're working on, and I'm really committed, our team is completely committed to actually making a difference on this front. I feel like with the Trump administration in particular, we have a unique opportunity. We have a receptive administration that is willing to look at this a lot more rationally, maybe than we had with the prior administration. So we really see this next 3 years as a real opportunity on the regulatory front. And our team's out here we're going to go get it and ideally make some progress in the near term on that.
that's fantastic stuff. And just to close out, I know we're just about out of time, but let's as a culmination of this discussion, let us know how we can help. Me as an attorney, operators listening, anyone in the industry that's listening. What is it? How can we make our voice heard to support your initiatives?
Absolutely. Yeah. No, it's important. And I'll say it in closing. I mean, I think the main thing is to be engaged with your local policymakers. You have to make it your responsibility to get to know your local policymakers. When I say local, I mean your members of Congress. You need to know them. You need to ask them to come to your facility. You need to involve them in what you do, Veterans Day events, all these things. Anything that can expose them to the good things that you do is makes the work here easier. And I have, tens of stories where that's actually happened. And where these relationships at a local level have actually changed massive national policy based on just the experience and the relationships on the ground. So we got to own that. So I just view this as like it's not an option. we got to get out there and we got to get to know these folks. We've got to engage with them. We got to help them solve problems. We got to, I would say get the cell phone number. You should have their cell phone number. You should be able to talk to them. They ought to view you, if you're in my district, as the expert on this policy. And the gold standard to me is that if local operators can become the resource of the Congress member when policies arise and issues happen, and I need placement of so and so for my second grade teacher who's now needing long-term care, that's success. And that means you become a part of the solution. And then when we have a problem from some dumb idea that comes way up here, we've got friends down here that know they have to pass that law that know that's not reasonable. We're not going to do that. We're getting there. And I feel really good about a lot of the progress that we've had as a result of those type of relationships. But that is the number one thing I need every one of your clients to do. Take responsibility to own the relationship with your member of Congress, Democrat or Republican. I do not care. We need them all. Whether you agree with them philosophically on a political side or not, it shouldn't matter. That I'm not asking you to write them a check. I'm asking you to engage with them and educate them. You have a responsibility to do that. And I think, and I've seen it, Democrat and Republican, help us deal with some irrational, crazy stuff that's happened. We've had Democrats help us with the staffing mandate. I mean, it was Democrats that pushed back on that. And most of the Democratic Party wanted to do it, but there were several that took a stand, and that was based on relationships, and they were willing to do it for their local constituents. So in my mind, David, that's what we got to do, man.
That's fantastic advice. I mean, who knew that relationships drove progress? It should be logical, but often it's lost. But listen, we appreciate your time here today. We appreciate all of your work and the advice and the information. And, good luck with everything you're doing. And thanks so much.
Hey, we appreciate you, and thanks so much, and look forward to working with you.
Yeah, absolutely.
Thanks again.